So let's talk a little bit about standard, ordinary vanilla colon cancer patients that come into the office, and talk a little bit about genetic testing. Michael, what's sort of your thoughts on, in essence, required gene testing for, let's do metastatic colon cancer? What do you want to know?
I think we'd all agree that knowing the RAS, KRAS, and NRAS, and having the extended testing done is important. BRAF, most people I think would agree it's worth checking the mutational status as well, and of course MSI if it hasn't been done.
So those are the keys you can't really, you got to know at some point.
I think you need to know those early on. The reality is that if you looked, you would find out that your center may not be doing the extended testing. We found out ours wasn't doing the extended testing in-house, and so we're often sending it out anyway. We get these larger panels as a matter of fact because we want to know about the RAS status. We find out everything at the same time.
I think this is one of the biggest challenges we have in clinical practice. I mean, we all have EMRs, and the results are coming from different shops, and they're scanned into your, and it's a bad copy, and everybody's reading different things, and you find KRAS wild type or whatever, and you think, okay, I got it. But isn't the answer there? What you got to check more?
Yeah, I mean that happens a lot. I mean, just simple logistics things about exactly like you said. Testing comes in a variety of places. Where do you even find it in the medical record sometimes? Which is a challenge.
Yeah, and then interpreting the result and having enough tissue to send out. So it's a really big deal for us.
It's a big issue
right now. I'm always impressed how much they can get off a colonoscopic biopsy. They seem to be able to do like next-gen sequencing. They get a good grab. Anybody saying that that's not representative and I need to biopsy the mat?
I think it's interesting if you can to biopsy the MET, because obviously the mutations change over time. Not all of them, but it can happen.
Do I need to, though? If I've got a brand new diagnosis, I've got my sigmoid biopsy, I've got liver mets, can I do the profile on the primary?
I think you can.
Everybody okay with that?
Yeah. We are, but now let me ask a question about, again, if you have a small sample and you want to know MSI, are you satisfied with what most people do as IHC, or do you want to push for PCR as well?
So let's talk about it. So our standard, I would just share, is that you start with the IHC, but we're doing a lot of these broad panels as well, which give you the IHC, plus we use, and it comes back as the next-gen kind of analysis. So it's basically the fragment analysis. Others? Or?
We've seen that PCR and IHC for the most part are pretty concordant, so I wouldn't get a PCR if I've gotten an IHC. The next-gen sequencing, still learning how to use it. Now, the sequencing can look at many more microsatellites than PCR can, so could you get a broader perspective? But so far, the word on the street is that next-gen is about as equivalent and concordant with PCR, but it's more convenient if you're going to order one of the next-gen panels anyway, go ahead and get that as part of it.
Other practice patterns up in Cleveland?
Yeah, about the same. I mean, most of the time we have next-generation sequencing that kind of gives you the slew of things that you need to know. So,
yeah, and for our observation, for our docs out there, is you get that protein panel back, the IHC panel back, present,
right.
and the patient and everybody think, oh, they've got Lynch syndrome or something, when in fact that's normal. So the language is terrible around this, and really confusing. Who gets MSI testing?
Everybody.
We said that earlier. Everybody still, so everybody early, right? Even though maybe indications are for later, for when therapy would play into that. So everybody's in on that. Why early? Trials, right? So they're.
And also, as mentioned earlier by Johanna, I mean, you never know if you have the one patient that you're detecting Lynch syndrome on.
Yeah, and then finding those patients. So let's say the tumor, let's take that a little further. Let's say the tumor comes back positive, so a couple of proteins missing. Maybe not a family history, maybe a 72-year-old first ever cancer in the family. So what's next? How do you handle that?
BRAF mutational status, because we know that there's a correlation. If you have a BRAF mutation, this is likely a sporadic mutation. So it's not germline, it's not Lynch. And if you are BRAF wild type and you have this, then it's probably Lynch. Now, one of the big questions that's come up now is that is that enough evidence to say that the patient has Lynch, or do you have to send off one of those tests to really confirm it? And that's something that's a little bit of an area of controversy, I think.
Do germline or not in that patient?
In that patient, we would send them to a hereditary counselor, and they would usually get testing. And keeping in mind, it's not always paid by insurance, unfortunately, so people may bear
better
the
though,
cost.
but you're right. They have to fight for it depending on the insurer. So knowing MSI, frequency of MSI high patients in metastatic disease.
Very low, less than 5%.
Yeah, so low. So not expecting it. Some data that we've looked at says that the further around the colon you get, the less likely. So in rectals, it's less than 1%, for example. So the reason that matters to me is if you don't have it yet and you needed to get tissue, would it be worth the payout for that very low percent of finding it? Maybe it's worth it, maybe it's not, but we can talk about that. So let's talk about other genes. So we talked about all RAS, we talked about MSI, other genes that you'd want to know, or other molecular expression that
You mentioned BRAF already.
BRAF. And why? Why do I care about BRAF?
So worse prognosis, potentially clinical trials that are available for those patients. So it's
Let's
good
say I have a BRAF mutated tumor. I'm not eligible for if What are you going to do for me?
So for first line, there's some data that suggests that FOLFOXIRI-Bev is the way to go for these patients with the BRAF mutations. And then if you can't get to a clinical trial, there's a lot of debate going out there about, depending on how your tumor is behaving, whether or not you might think about using something off-label in terms of the targeted therapies, but really try to get those patients to study.
Yeah, Scott Kopetz's data in combination in that BRAF patient is pretty compelling.
Yeah, the phase 2 data is nice. There's a big phase 3 though that's ongoing, the Beacon study.
Right. It's going to take a while to accrue, and also on the backdrop of this positive data and being able to get access. So, so I think it'll be a challenge in today's environment when Scott's was very positive on that. And it is kind of the Wild West too about getting access to drugs. You call up, they say fine, right? Yeah. And it's really fascinating about that. Any BRAF studies?
Don't have any currently, but I mean in terms of clinical trials, but certainly we try to get patients to the right place.